This talk is, I think, a harder talk for me to give than the one yesterday because it's gotten more complicated as time has gone along. When I first started doing depression talks and depression treatment talks, there was an easy message to provide. Now the message has gotten more complicated. So I'm hoping at the end of this, you'll not feel too confused, I guess, and I'm happy to take questions. But anyway, it's a complicated subject. Here again are my disclosures, Bristol Myers Squibb and GlaxoSmithKline. So what I'm going to try to cover today is how to make sense of antidepressant drug trials. There have been in the last several years now a publication of a number of NIMH-supported depression trials that have been important. And then I'm going to talk about psychiatric adverse events or side effects and how I think clinicians should put the information together. It's probably not news to a psychology audience about the fact that there's different ways of determining drug response, but it's kind of good to review it with respect to what I'm going to be talking about with the antidepressant drug trials. We all know that there's statistical significance. And the problem with that is if your samples are large enough, you can have pretty trivial response differences, and it'll still be significantly different. Whether it's clinically meaningful or not is the operative question. We can look at clinically meaningful differences by effect size. I talked yesterday about effect sizes for ADHD treatments and mood stabilizing treatments. And we know that a good effect size is 0.8 or larger, a modest one is between 0.5 and 0.7, and a small one is below 0.5. And that can be somewhat helpful too. And I think, by the way, of effect sizes as moving a column, if you get an effect size of 1, it's moving a column that goes 0 sometimes, often, or very often, moving a column a little bit to the left. So if you're very often, an effect size is moving it to often. If you're often with the bad symptoms, then it's moving it to the sometimes. So that's the way I sort of picture an effect size. There's something called absolute treatment benefit, which is the drug response minus placebo response, and I use that a fair amount. And there is what gets used in drug trials, which is often a change from baseline in whatever the rating scale is that gets used. And if you the FDA often wants you to say that there's going to be a 50% response or a 25% response or some predetermined response change in whatever the baseline metric of severity is. There's also a way of looking at it in terms of the patients who respond or recover and no longer meet criteria for the disorder. So the bottom line is there's a number of different ways to slice the pie in understanding treatment response. The way people use the ADHD rating scale as a metric for determining ADHD response, or I was talking yesterday about the Young Mania rating scale as being the rating, severity rating that gets used in bipolar trials. The Child Depression Rating Scale, the CDRS revised, is the metric that gets used for depression severity. And that is not a parent rating scale, it's an interview rating scale. So after I finish interviewing a parent and a child and putting all the information together, there are a number of items which are anchored that you complete and come up with a severity scale. And basically the way it goes is a score of more than 40 usually is what gets you into a drug trial. Often a metric of improvement will be a response rate, a 50% drop response rate or partial response rate. And if the person is severe enough, if they have a 60 or 70 on the Child Depression Rating Scale, you can get a 50% response and still be significantly symptomatic in this yellow zone. A remission, meaning that you're really no longer significantly symptomatic, is a score below 28. And so, again, I like to use the fever metric because it's one we can all relate to. If you've got a temperature of 105, you're clearly sick. If you drop your temperature by 3 points, that's a significant drop in temperature. It's a clinically meaningful drop in temperature. You're still febrile. You have a temperature of 102. What you're looking for is a drop in your temperature to 98.6. And so that's kind of what this is, 98.6. This is maybe 101, 102, and this is 104, 105. There are a variety of other ways that you also determine remission. People have increasingly, by the way, been looking not only at symptom remission, but also functional remission, so that there are other things that you use to determine response and remission, which is a clinical global improvement score and also a clinical global assessment scale, CGAS score of maybe 60 or 70 that says you're also functioning, not just asymptomatic. So I told you yesterday about the drugs that are approved by the FDA that and everything else is considered to be off-label. Here is in the antidepressants where we are as far as what's approved for children and adolescents. Fluoxetine or Prozac is approved for the treatment of depression in kids between the ages of 8 and 17 and also approved for the treatment of obsessive-compulsive disorder. Sertraline or Zoloft is approved for the treatment of obsessive-compulsive disorder. And fairly recently, escitalopram or Lexapro has been approved for the treatment of depression in teenagers. There have been a number of other placebo-controlled trials that have been done, but those I'll show you in a minute the effectiveness of those. For those of us, and it doesn't look like there's many of you out there that remember the tricyclic antidepressants, but those were the first medications that were used for treating depression. In the 1960s and 1970s, they revolutionized depression treatment in adults. And many of us older folks got into the whole area of depression treatment in kids in the hopes that these drugs would revolutionize treatment in children, that we recognized that depression was important in kids, that it had a long-term morbidity. And our sincere hope was that if we got those kids, if we got the depression in those children treated early, we would make a major change in their lives. And so we were all really excited about going out and diagnosing depression. Depression rating scales and interviews and all sorts of things were developed and studies were done in the hopes that we would be able to do that. And unfortunately, what we found with the tricyclic antidepressants is that for a variety of different reasons, they just simply were not very effective in children. Now, the numbers of kids that were in those studies early on were pretty small, but no matter how you slice the pie, the problem was either that the placebo response rate was high and as high as the drug response rate, or the drug response rate was low and the placebo response rate was about equivalent. Either way, the tricyclics were not worth getting out of bed for in terms of making a change in the depression of the kids. And meta-analyses that have been done in children show an effect size that, that's in the minus range, really pathetic. In adolescents, the effect size is 0.47, not that bad. I have to tell you, one of the things that was really a hit upside the head for me, and I think for many of us in the depression area, was I had always been made to feel that children and adolescents were somehow different from adults in terms of their response to the antidepressants, that our kids just didn't respond as well. It turns out, as I'll show you in a minute, when you put all the adult studies together, especially the ones that were never published, the adult response rates were not that wonderful either. For a variety of reasons, though, the tricyclic antidepressants really have become more of historical significance because when you look at any kind of treatment, you're looking at risk versus benefit. That's why I started this talk with that scale, because in what I'm talking about, you're going to be looking at risk versus benefit. And what it came down to with the tricyclics was, even in the cases where there was some indication of improvement, the fact was there was a significant risk involved that these drugs could be fatal in overdoses, that on rare occasions they caused arrhythmias. They were somewhat difficult to manage because of those threats, meaning that you had to get EKGs. And so, by and large, many people felt that the risks outweighed the benefits. So at this point, this is the scorecard of industry-supported pediatric depression trials. These are the ones that are the positive studies. There have been a couple of NIMH-sponsored studies as well as an industry-sponsored study. There have been a bunch of these that are sponsored, and these are the ones that have the positive FDA approvals. But there have been a number of other studies that have not been very impressive at all. And if you look at the absolute treatment benefit, remember that's the one where you've got the drug response minus the placebo response. I found that this was kind of a way to kind of look at a glance at how these things come out. I put the adult ones here just to say that this is kind of, I'm a developmental, person interested in developmental psychopathology, so I'm always looking at kids through the ages, and so this is how the response goes in adults. This is the response of fluoxetine in the TADS trial, looking at fluoxetine and CBT combined. So that's a decent absolute treatment benefit, 35%. In other words, the drug beat placebo by 35%. In the TADS trial, this is how fluoxetine alone came out. This is how CBT alone came out. This is how fluoxetine has come out in other studies, not the TADS trial. So you can see why fluoxetine, for whatever reason, seems to do better in these studies than some of these other medications. The absolute treatment benefits of these other drugs over here are fairly low. There's only even in the sertraline trial, which was approved by the FDA, there's only a 10% difference between drug response and placebo response. What they did with that is they gave the sample size, made the sample size large enough, so that did turn out to be statistically significant. So that's the absolute treatment benefit. This is how the effect size looks on the Children's Depression Rating Scale for the most part. And again, this is adults with the serotonin reuptake inhibitors. This is fluoxetine in its various disguises. And this is some of the other medications that have been used. So as you can see, by and large, the effect size comes in at around 0.4, except for fluoxetine, where the effect size is larger. Now, there have been, as I said before, a series of recently completed NIMH trials that have tried to tackle a number of different questions. The TADS trial, the Treatment of Adolescent Depression study, as you know, was a trial where they were trying to look at state-of-the-art treatments in depression in adolescents, where they looked at fluoxetine alone, CBT alone, the combination, and there was a placebo in terms of a medication. I mean, there was no placebo for the CBT, but there was a placebo medication arm. And the ADAPT study is a British study where there was no placebos. The Europeans are not excited about placebos. And so this was a study comparing CBT and fluoxetine plus fluoxetine alone. The tortilla study, the treatment of resistant depression in adolescents, was designed to answer the question, if you don't get a response to the first serotonin reuptake inhibitor, what do you do next? And so we'll talk a little bit about those studies. Again, this is a summary of the TADS trial, and I've assembled it this way to make a couple of points. I look here at the various arms, CB2, fluoxetine, CBT, and placebo. And the point that I want to emphasize here is you can get different rates of improvement depending on what metric you use. If you use no longer meets criteria, you're up to about an 80% response or recovery. If you look at response, which was a 50% decrease in the score, it's a little bit less. If you look at remission, meaning that score was below 28 and there was a real significant improvement in your functioning, down to remission, and there's the functioning score, you're at a much lower rate. So, it shouldn't be, it's not rocket science to figure out that the more stringent your criteria are for improvement and recovery, the lower the rates are for all of the various arms. The moderators and mediators, and you're going to hear various ways of shaping this as I go along, really come down to the deeper you are in the hole and the longer you've been there, the harder it is to get out of the hole. So the higher the depression scores, the longer you've been ill, the more suicidal you've been, the more hopeless you've been, the worse your functioning has been. the more likely you are not to respond very well. If you're kind of negative in terms of what's going to happen to you, if your coping sucks, if your SES is low, if you've got a lot of comorbidity, if there's a lot of family dysfunction, if there's a lot of exposure to negative events, you're not likely to respond as well. So again, you know, it's not rocket science. In some conditions, the sicker you are doesn't seem to make a distinction in terms of recovery, but certainly in depression, it does make a difference. This is a follow-up study now in the TADS trial, and the point of this is to look at what happens to the various treatment arms over the course of time. Depression is a ratty enough way of feeling that the sooner you get over it, the better you are. But there's also the long-term view of being able to say to somebody, you know what, you may not be better now, but I can say over the long term, a year from now, things are going to be better, or maybe things aren't going to be better. But there's a difference between how soon am I going to get better and am I ever going to get better. So that's what this slide is. This is a how soon are you going to get better and are you ever going to get better. And what it says basically is the combined treatment gets you a little bit better sooner, fluoxetine gets you a little bit better sooner than CBT does, but over the course of time, and after 12 weeks, by the way, there's no longer a placebo arm, but over the course of time, by 36 weeks, by 6 months into the year, basically, everybody is at about the same rate of recovery, and you know, at 12 months out, everybody has had about the same state of remission. So, you know, the heavy-duty interventions get you better faster. Over the course of time, you'll get a significant number of people get better sooner or later. An important question, though, is at what point do you want to throw in the towel as far as medications are concerned? As a prescriber, as a physician who, you know, dispenses these things, it's an important question to me. In a drug that may take a while before it shows a benefit, when do I say, you know what, let's switch horses. This is just taking too darn long. And you're going to see as I go along that there's some consistency in what turns out to be when you throw in the towel. This was an open-label fluoxetine study that was designed to look at exactly that question, dividing the remitters by the non-remitters, and at what point did you get a separation in terms of the scores. And it looked like at about week 4, the reduction of 50% sort of best discriminated who decided to remit and who who remitted and who didn't remit. In this study, interestingly, children responded as well as teens. It was an open trial, though, and family history was a predictor of response. Now, this is the ADAPT study. This is a study that was done in the UK. The CBT that they used wasn't quite the same CBT that was used in the TADS trial. This was an effectiveness study. This used a manual for CBT that family practitioners could read and use. You might argue that it wasn't good enough or there wasn't enough homogeneity in training or whatever. But what the Brits felt is, you know what, we're not going to be able to do grad student level gorgeous CBT out there in the boonies. What we're going to be able to do is what a doc is going to be able to do in his or her office. So let's just see how good that is. And especially in the UK, where they've really eschewed the antidepressants and said, we really, really, really don't want you to use these things, they're poison. It's interesting that in their study, by and large, CBT did not add anything to antidepressant response. There's been a lot of discussion about why CBT didn't seem to do as well in the combined treatment arm as it did in the TAD study. And one of the things, maybe I'll show you in a minute, is that the kids in the British study were probably sicker. Overall, the time to response and the percent of response wasn't that different, as you can see in the SSRIs and the CBT and SSRIs, and actually not that different even than in the TAD study. But if you look comparatively with the ADAPT study and the TAD study, you can see that the Brits had higher rates of comorbidity. Their functioning scores were lower in however you wanted to mention it. There were higher rates of suicidality. At 12 months, they were still quite a bit better, only 1.5 compared to 2 standard deviations of improvement, but still a significant improvement over the 12-month point in time. So it isn't that the people didn't improve, not as many improved as much as in the TAD study. It's not clear what the difference is between children and adolescents in terms of response to medication. But here is kind of a summary slide of the difference between antidepressant and placebo in children and adolescents. And as you can see, the difference here is, less than 10 points. The difference here is like maybe 15 to 20 points in terms of the absolute treatment difference, and this is significant, and this is marginally significant. And the reason basically has to do with, as I hinted at before, is the fact that the placebo response rate seems to be higher in kids. It's higher in teens, in fact, than it is in adults, but the higher the placebo response, the lower the, obviously, the total treatment benefit. When I first started studying depression back in the 1970s, the placebo response rate was much lower than it is now. So there is something about how these trials, industry-sponsored trials, is being done that is increasing the placebo response. And there's a variety of theories and hypotheses about that. There are some people who feel that one of the reasons that kids don't improve, when I say kids, I mean children below the age of 12, don't respond, is that the pharmacology may be different in children. They have a different pharmacokinetic response to the drugs. And that may mean that you have to change the dose of the drug or change the duration of time that the kid gets the drug. Depression, as much as we might talk about it, is not occurring, in millions of kids. The rates of depression in prepubertal kids is about maybe 2%, that's not that many kids, and it's difficult to get that many kids into a treatment trial. So what you have to do is you have to do a multi-site study in order to do it, unless you're really a big site that, kids come from all over the state to your place. You're scrounging around looking for depressed kids to be in your trial. So it's a lot of sites. The more sites there are in a study, the more likely you are to have a placebo rate that's high. Kids, by and large, that have depression have had depression for a longer time. And so, as you saw, one of the predictors of non-response, even in the adolescent trial, is longer duration. Some have hypothesized that early onset depression is a harbinger of bipolar disorder, and bipolar people don't respond as well as tricyclics. Personally, I think that's a lot of Monday morning quarterbacking. I don't think there's any validity to that, and there's been one study that looks at it and said, no, that's not the reason either. Some say that the duration of trials isn't long enough, though recent data says that really you start to get a response by 4 to 6 weeks, so that's not the reason. My personal opinion is the drugs we have are simply not effective enough, and that's what you heard from me yesterday, and it's what you're going to hear from me today. Among the predictors of placebo response rate in internalizing disorders, lower placebo response rates are associated with Caucasian race, male gender, washout period in the study, meaning that you have a period of time during which you kind of futz around, and if people are going to have a flight into health, those are going to be the placebo responders, and they sort of leave your study early. Longer duration of illness, type of internalizing disorder, so the placebo response is lower in people with a obsessive compulsive disorder and anxiety disorders in general than they are in depression. Actually, one of the more savvy industry-sponsored trials that went on a number of years ago was in a drug called fluvoxamine, where the drug company, and I forget which one it is now, anyway, wanted to go after an indication for the use of their drug. Luvox is their brand name. And so the guy who headed the trial said, let's not go for an indication in depression because the placebo response rate is higher, and so we need a larger sample in order to show significance. Let's go for OCD. OCD is much rarer. But the fact is we'll show a drug placebo difference with a smaller sample size, and once docs know it's okay for OCD, they'll use it for everything else. And indeed, they showed that it was effective in OCD, and they didn't need a larger sample, and so, you know, I thought that was actually a good way of using what we knew. A general rule of thumb when you look at a study, when you see a placebo response rate of less than a third, the drug is going to be better than placebo. When it's over 40%, the placebo is generally either superior or there's no difference. So let's talk about tortilla. When I see tortilla, the word that comes to mind is contortion and torture. That wasn't the reason why they picked it, I don't think, because I don't think they realized it was going to be such a torturous study before they did it, but it sure as heck turned out to be that way. It took 7 years to complete the study, and part of the reason for that is along the way of doing the study, the black box warning got issued, and of course, everything had to come to a screeching halt while everybody deliberated about what they were going to do about that in the study. So that was a definite problem. But also finding depression, I told you, is not that easy, and finding treatment-resistant depression wasn't that easy. So it took 7 years to get 334 teens, and the criteria basically was that they had no response or an incomplete response to an adequate trial of one selective serotonin reuptake inhibitor. And what they did is they first just tried a couple of weeks of increasing the dose of whatever it was you were on to see whether that would help. And that got rid of a few people, but it didn't make a huge difference. So then what happened was they asked the question, well, what would happen if you changed to another antidepressant, either a selective serotonin reuptake inhibitor like fluoxetine or sertraline, those drugs, or a combined serotonin norepinephrine drug like venlafaxine or Effexor. What would happen if you switched to any one of those or CBT? Which would help sooner? What would help more? And what would decrease the likelihood of relapse? Because one of the things that is important to realize whenever you get a remission in depression, a significant number of people will relapse over the course of the next year. So they wanted to know what to do next, what would be the most effective. So as I said, you were randomized to SSRI and SSNRI and CBT. And the CBT was added to the antidepressant or venlafaxine. So what happened was basically it didn't make, and this was blinded treatment for 12 weeks and then open treatment after that and then naturalistic follow-up. So the first thing that came out was the difference between those that did or didn't get CBT added on to their medication regimen. And as you could see, the people who had whatever it was they had and got CBT did better than people that got whatever it was they got without CBT. It didn't matter what drug you got, okay? So the answer to the first question was, doesn't matter what you switch to, just switch to something else. And at least in the initial stage, it looked like CBT was helpful, additionally helpful. Over the course of time, the next question is, how soon could you tell that the new strategy was helpful? And it looked basically like, again, around 6 weeks, there was a difference between those who were going to remit, and those who were not going to remit. By the way, when people decide on remission, you remember that little thermometer that I showed you, remission is defined a priori, and in this particular case, remission was defined as 3 weeks of very few symptoms, okay, 1 or less symptoms. Relapse, meaning you got sick again, was 2 weeks of definite or probable depression. So by and large, 2/3 or so of those who had remitted by 24 months had shown a definite clinical response by 12 weeks, and you could already see the difference beginning at 6 weeks. Over the course of time, what happened to people over the next year was, as I said, about 61% ultimately responded. But what was interesting was that even when people no longer met criteria and seemed to be better, they still had some of those cognitive symptoms that told you that they were not squeaky clean. They still had a low self-esteem. They were still somewhat irritable. They still complained of fatigue. Remission predictors, lower initial scores, meaning less depressed, shorter episode duration, less severity, better functioning into the trial, less suicidal, non-suicidal injury, cutting, borderline kinds of things, less substance abuse. Demographic variables and comorbidity were not predictors. But again, more information that says the deeper you are in the hole, the less likely you are to climb out of it. The relapse rate, so 61% seemed to get significantly better during that period of time. About a quarter of them relapsed. It didn't matter what kind of drug you had, didn't matter whether you got CBT or not. Suicidality declined, and this is how this is basically what the trajectory looked like over time in the course of the 72 weeks. However you sliced it up, there were clear differences between those who remitted and those who didn't remit. And it was really seen by about 6 weeks. And this is the slide that basically shows that even among the people who remit, there's a black bar here, there are still some symptoms there. Certainly, better than the people who didn't remit by definition, but it still is some interest, the fact that 30% of the people still had low self-esteem. There was some sleep problems, irritability, fatigue, et cetera, et cetera. Another question that comes up is, how long do we have to be on these drugs? Jessica and I were talking on the way here about, is there a message that we would have for parents about medication use? And I would have to say the one question that comes up over and over again when I see a parent of a child for whom medication is going to be an issue, it doesn't matter what the disorder is, the question the parent always has is he or she going to be on drugs for the rest of his life? Is this a lifetime sentence that I'm looking at? And my candid response is, I don't know what's going to happen tomorrow, for God's sakes. I can't tell you what's going to happen to your child for the rest of his life. But my standard response is that you treat somebody for the symptoms they have. Our job, my job, I feel, as a child and adolescent psychiatrist, is to get that kid through childhood with as few scars as possible. I want him to have a solid base in terms of his self-esteem, in terms of his academic functioning, in terms of his peer functioning, in terms of his functioning at home. My job is to get him to adulthood with as many options as he can have. And so I am looking towards treating the kid, getting him or her asymptomatic, solidifying those gains, and then pulling back on whatever the treatment happens to be. For ADHD, that's not so hard because for the most part, the drugs that we have, as soon as the drug stops, like that night, if the kid is symptomatic, it's not rocket science to figure out whether or not the kid is still symptomatic. Maybe as he gets a little bit older, it's harder, but the fact remains, you get a fairly rapid answer with that. With the bipolar medications that I was talking about yesterday, you can get a fairly fast answer with the atypical antipsychotics. They're fairly short-acting. When you stop them inside of a couple of weeks, you usually know whether you're getting symptoms back again. With the antidepressants, because it takes a long time before you really start getting the treatment effect, I'm telling you, 4 to 6 weeks, knowing when to stop is much more much more of an art than a science. And so studies have been done to try to look at how long you should keep the person on, and is there an advantage of it over the course of time. Again, this is not a study for the faint-hearted. So, here's a study looking at sertraline, open trial, given the sertraline. If the people responded, 51 of the 93 people responded, they were on it now for the next, 6 months or so. And then people who continued to respond were then randomized to sertraline versus placebo for the rest of the year to see what the relapse rate was. And by and large, the 38% of people who were on the sertraline maintained their response, whereas none of the people on placebo maintained their response. So that was a significant difference. It doesn't knock your socks off, but it does say that there is some edge to continuing the medication out for at least a year. And we say a year for the most part because depressive episodes, by and large, last about 3/4 of a year to a year. And the hope is that you're building enough skills in with other interventions so that hopefully when you stop the medication, you will decrease the likelihood of a relapse. So if we look at this summary of treatment studies of adolescent depression with respect to CBT, in some studies, combined CBT and medication was better than medication alone. It was on some outcomes, not all outcomes, and in some studies, but not all studies. It doesn't add much in severe depression. The deeper in the hole you get, the harder it is to pull you out with CBT. In tortilla, the treatment-resistant study, initially it looked like CBT was helpful, but the between-group differences did not persist to week 24. Tortilla, like ADAPT, as I said, did not find a signal for the protective effects of CBT. And depression is different from anxiety in this regard, which I'll talk about in a minute. Putting all of this information together, John Walkup had a nice editorial in the American Journal of Psychiatry about how he would integrate this into clinical practice. And his take-home message was that when you treat depression, you need to be vigorous about it. Clinic visits were weekly and dose adjustments were brisk. I say that because insurance companies don't want to pay for a lot of treatment, and so frequently fallback position is once a month revisits, not good. Data suggests that doses should be adjusted quickly and to use adequate doses. For complex treatment-resistant cases, try to find that out as soon as possible. How long to wait before switching antidepressants is not fully established, but remission is usually demonstrated. You get a good signal, usually by 8 to 10 weeks conservatively. If there's minimal response or failure to response by 8 to 10 weeks, it doesn't preclude later improvement. But I think the general feeling is don't drag your feet in terms of changing what your strategies are. In contrast to the industry-sponsored trials, which I showed you, which were very unimpressive, the feeling has been that the investigator-initiated studies, such as TADS and ADAPT and tortilla, suggest that treatment for at least teen depression can be, with medication, can be effective and implemented safely. And it's important to make sure that the kids get to the clinic and get there early in their course of treatment. The bottom line from my standpoint, the drug produces some improvement in close to 2/3 of children and adolescents. Unfortunately, placebo works in about half, so it just really is not it's just not as good as you'd like it to be. The teen response is more robust than child response, and part of that is because of the placebo response rate. In general, efficacy was inversely proportional to the duration and severity of the depression. CBT was okay in mild depression and may add to treatment-resistant depression. Close follow-up with attentive treatment is needed. And by and large, the algorithm in terms of medication is an SSRI, add CBT, try a different treatment, SSRI or SNRI, you can add CBT to that. I'm not going to talk a lot about anxiety. I only have a certain amount of time to talk, but the take-home message is not difficult as far as the medication piece is concerned. And that is that for reasons that I don't understand, kids with anxiety respond better than kids with depression. And here's a good example of that. This is an intent to treat population of children and adolescents followed with paroxetine or Paxil. Paxil has not been shown in a number of studies to do a damn thing in depression in children or adolescents. But in children and in adolescents, there's a distinct improvement compared to placebo. If you compare the same drug in kids over time, here's placebo, here's paroxetine in anxiety, here's placebo and paroxetine in depression. Does not take a rocket scientist again to see the difference there. This is a generalized anxiety disorder and major depression with venlafaxine, with Effexor. Again, significant difference in anxiety, not a rat's patooties bit of difference in depression. So I can't explain that to you because, as we all know, anxiety and depression are kind of joined at the hip. In terms of the efficacy of CBT, at least in the study that looked at sertraline, CBT, and the combination, a much clearer signal for the combined treatment than we saw even in the TADS trial. So for whatever reason, anxiety conditions, maybe because their onset is earlier, the kids aren't in the hole as deep for as long, I don't know, but anyway, they seem to do somewhat better. So now I'm going to talk about, I talked first about benefits, now I'm going to talk about risks. Nothing simple, just the way I told you that defining effectiveness varies by what metric you use, the same thing is true for adverse events. Depends on how you elicit them, whether you wait for the person to complain spontaneously, whether you use a rating scale, whether the rating scale and spontaneous reports agree with each other. Do you determine them a priori? When you use efficacy, when you do a study of treatment response, you have to say in the beginning what you're going to measure. So the analogy I give is, if you've got a drug for the treatment of depression, and it turns out that it grows hair on bald men, you can't say to the FDA, well, you know what, it was a crappy treatment for depression, but whoa, did it grow hair? The FDA would say, well, that's interesting. Now you've got to go out and do a trial using a measure of hair growth. So you've got to say at the beginning what your efficacy measure is. And it may be that in the beginning what you need to do is the same thing with side effects, so that you're measuring those things systematically the same way you're doing the efficacy. As far as the side effects are concerned, you want to know how serious they are. Did it cause study dropout? Was the symptom present but not troubling? And can you tell if the symptom that you're getting is the condition you're treating versus caused by the treatment? So one of the things that you have to count as an adverse event is mania, okay? Well, if you're treating mania, you say, well, why is mania an adverse event? If somebody drops out of the trial because their mania gets worse, believe it or not, you have to put that down as an adverse event. Well, what it means is the drug didn't work, not that it caused you to get manic. But there's a very arcane way that these things operate. So suicidality, as we all know, has been one of the real bugaboos in the treatment of depression. It's one of the important symptoms of depression, and the question is do the treatments make suicidality better or worse? And there's been lots written and so forth and so on. I can't give you an absolutely clear answer, but what this slide is going to do is to say that it really depends on how suicidality is measured. So you can have, for the TADS trial, for instance, there was a suicidal ideation questionnaire that was used to determine suicidality, and you could see whether that suicidality questionnaire, got worse. There's a suicidality item on the Children's Depression Rating Scale. You can see whether that got worse. Or you could wait for a parent to come in and say, George or Mary talked about being suicidal this week. He hadn't talked about it before, in which case that's a spontaneous report. And depending on which one you use, again, you see very different frequencies and different frequencies of the different interventions in the TADS trial. Here, by the way, is the suicidality item on the Children's Depression Rating Scale. Understands the word suicide, but doesn't consider himself suicidal. Sharp denial of suicidal thoughts. Has thoughts about suicide, hurting himself, but hasn't done anything about it. And as you can see, the score gets higher as the person gets more suicidal. And so one of the ways of looking at this was, any change in this measure. Interestingly enough, that gets done every week. There was no difference between drug and placebo looking at that measure. Where there was a difference was in spontaneous reports of suicidality. So when the FDA did a meta-analysis of all of the various antidepressants to look at the question, is there more suicidality on antidepressants versus placebo, they came out with the fact that there really was a difference. It was a very small difference. That's basically what this is. But for the most part, it wasn't negligible. There was these tiny little rates of suicidality. And so it sort of came down to about 4% of kids in drug trials had spontaneous reports of suicidal ideation versus 2% in the placebo group. And that was, over the course of the trials, significantly different. So that's the first thing. The second thing that's really kind of interesting is this slide. And this slide basically says there really is a difference between children and adults in this business about suicidality. Whether you look at behavior, and then we're looking, by the way, at behavior or ideation, not people jumping off cliffs or anything. But still, it's disturbing when your kid says, I want to kill myself or whatever. So I'm not trivializing. I'm just telling you, we're talking about behavior. We're not talking about death. The fact is the behavior rates are very high in kids, and they're fairly high in young adults. It really doesn't start to come down to no difference until late young adulthood, like after the age of 25. And by the time you get to Gomerdom here, which is where I am, there's no difference. So, so there's something going on here that lasts until adolescence, young adulthood, that disappears over here. And I think many of us have some hypotheses about what changes there are that are taking place. But that one of the things that seems to have an impact is whether you voice wanting to die. One of the other things that's interesting about this whole suicidality rate is it isn't just the drug, it depends on the condition. So it really is only in the depressive treated people, kids who are getting the SSRIs for their depression, where you see that drug placebo difference. You don't see it in OCD and anxiety disorders. Another question is, have the drugs done more to improve depression than they have to stir up the pot as far as suicidal behavior is concerned? And again, there's a lot of argument about that. This is a study that was published in 2006 where the people tried to look at rates of depression over the course of time, rates of depression really making a serious decline here. At the same time, the use of fluoxetine increased. And that's been shown in a number of different ways, in a number of different countries, a number of different regions. All of it is circumstantial evidence. Circumstantial evidence is suggestive that the medication has been helpful. What other kind of psychiatric adverse events do we have? Well, the most important other one is the one that we talked about yesterday, which was the activation. The fact that some people, some kids look like they may develop mania, they have trouble sleeping, they become more irritable. It's quite striking when you see it, and that activation business is there's a lot of different terms for it, but activation is what I'm calling it. And as you can see, the rates vary very much by drug. Paroxetine, Paxil has the highest rates, venlafaxine and sertraline have somewhat higher rates. The fact is you can get activation with any of the serotonin reuptake inhibitors. And It's not a huge issue, but it's an issue when you see it. I showed you this slide yesterday about the age effects on behavioral toxicity. Basically, this is a phenomenon that occurs much more commonly in younger children. The younger the kid, the more the problem. Developmentally disabled kids have more of a problem than non-developmentally disabled kids. So the bottom line on adverse events is that, and I didn't talk about the somatic events because that just wasn't the point of this talk, but I'll mention it here. The somatic events, headaches, stomach aches, those kinds of things, not different from placebo. The rates are usually less than 10%. The adverse events of greatest psychiatric relevance and concern were the behavioral activation and suicidal behavior. The activation rates varied from study to study from 2 to 26%. Younger children were more vulnerable. Developmental disabilities, I said, were more vulnerable. As far as the suicidality business is concerned, the rates are very low, but they're always higher on medication. The emergence of suicidal behavior on medications is about 3 to 4% versus 1 to 2% on placebo-treated kids. Higher in younger people up to age 25. Relationship between the disorder and the drug. And the scorecard here that I thought was very helpful, it was published a few years ago, to look at that risk versus benefit is this. I was talking yesterday about number needed to harm and number needed to treat. The number of people that you need to see and treat before you get a response is the number needed to treat. The number of people that you see before you get a serious adverse event is the number needed to harm. So obviously what you want to have is a low number needed to treat. You want to be able to see fewer people before you get a response, and a high number of number needed to harm. You want to see, you want the adverse event to be very, very rare. So you want to see lots of people before you get an adverse event. So here's the scorecard for depression, obsessive compulsive disorder, and anxiety. The number needed to treat, the number of kids that you need to see before you get a response in depression is 10. For OCD is 6. For anxiety is 3. Okay, so there you see the relative responses of the medications in the various conditions. And here you see the number needed to harm. 112 kids, 200 kids, 143 kids. So there's the difference between depression and the anxiety things. You still have a the adverse event of suicidality is much rarer than treatment. So overall, it seems to me that the merits of treating outweighs the benefits of fear as far as the risks of suicidality is concerned. Again, the effect size for the, and the studies that were used for this did not knock your socks off for the depression. It was certainly better for OCD and anxiety. So what you've got is, you've got a not bad, not great treatment, but it shouldn't be the fear of the adverse event that puts you off giving it a try. Now, the black box warning that was published a few years ago was done as a result of this FDA meta-analysis. And so the FDA basically put a black box warning on all of the drugs. Didn't matter whether, that particular drug turned out to have a difference in placebo or not. Painted all by the same brush. Basically saying, the risk of suicide is terrible! Scared the crap out of everybody. And it scared the crap out of the primary care practitioners who said, whoa, I'm not going there, guys. They were the ones that were treating the most kids. And it may be for the good that people were handing these drugs out like water, and, there's no free lunch here. So basically what happened was that the reins were really put on treating depression, and the rates of treatment and antidepressant prescriptions really dropped in young people compared to older people. And then what happened was the fact that there seemed to be a blip of increase in actual suicides. Now, as you can see, and if I had a longer one, you'd see the waxing and waning of suicide over the course of the century. It really does wax and wane. So the question is going to be, does this increase in suicide that coincides with a drop in treatment of depression, is that going to be a continuing escalation, or is that just a momentary blip? So far, it's continued over here a little bit. Again, circumstantial evidence. But depression is not a benign problem. And suicidality, meaning you think, you talk about it or whatever, isn't something you want to hear. But given a choice between somebody saying they're going to do it and somebody doing it, most of us would prefer to hear about it rather than having somebody kill themselves because they're really depressed. So the data aren't all in. I can't give you a final, conclusion here. But that's kind of the way I look at the evidence. And this was an editorial that was published a couple of years ago by one of the people that's been looking at the rates of suicide versus the rates of depression treatment. And basically what he says is that that the risk of attempting suicide goes down after starting antidepressant treatment, that if you get rid of the depression, the risk of suicide obviously decreases. Antidepressants help many people. Some do have negative reactions. And so therefore, it's really important to have regular contact with the person that you're treating over the time you're treating them. The thing that's difficult is that there's no point of rarity here. There's no time when you can say, well, you're out of the woods now, it's been 6 weeks and we haven't heard a peep out of the person. It doesn't necessarily mean you're not going to hear a peep in the next 6 weeks. So then the practical issue comes down to how close should the contact be, and what do you do? Interestingly enough, for all the black box warning scared the crap out of everybody and said close contact, frequent visits, etc., didn't change anybody's practice. So I think the bottom line really is, and I'm in a tertiary care center, I'm a professor, I teach fellows and residents and so forth and so on, and we have the luxury in a teaching hospital to take good care of our patients and to closely monitor them. It doesn't mean that they have to put their foot in your clinic every day that you can check up with them. You give them the information they need to have. The black box warning, in one respect, isn't bad because it makes you talk about what those risks are, and parents need to get a frank discussion of what the risks are. They need to know that they can call, they can get in touch with you, et cetera, et cetera. They need to check in regularly. Even when you're in the maintenance phase, you need to check in regularly by phone, by visit, whatever it is you want to do. You want to just make sure that people are aware that they're on a medication and that this is not, as I say, a free lunch. So the black box warning was useful in terms of, as I say, making you talk about a risk that is there, but it should not inhibit you from treating somebody that really needs to be treated. So my summary basically is that the benefit of most antidepressants in children and adolescents is modest. The benefit in anxiety disorders is better because the placebo rates are lower. The risks of suicidal behavior and activation are small, but consistently associated with antidepressant medication and in younger people. Given the morbidity of mood and anxiety disorders in kids and adolescents, treatment should still be vigorously pursued. It's just necessary to be honest about both the benefits and the risks. So I keep talking about the whole. This is my, I copped this from a political cartoon. But the way I look at it is people that are depressed are in a deep hole. And whether it's antidepressants or CBT, the ladders that we have are not getting them out of the hole. We need a ladder to get them out of the hole. And we're not there yet. So, that's it. Thank you.